Ladies and gentlemen, dear friends, thank you for joining this session sponsored by Jafron at the ERA meeting in Milan, Hemoadsorption in chronic and acute clinical settings. We're just finished the Vicenza International course on AKI and CRRT, and I must say that in almost every session, the concept of adsorption was discussed and debated, and the community of critical care nephrology also convened 3 days before the course in one of the ADKI consensus conferences. You might be familiar with ADKI because we generated the rifle, we generated the cardiorenal, we generated the renal dose, different concepts. And finally, we had a consensus conference on adsorption. So I think this is the hot topic of the moment. Everybody is invited to contribute to more information because we said that we are today with adsorption where we were 30 years ago with continuous renal replacement therapies. So hopefully it will not take us 30 years to come to the final conclusions that are not so final, by the way, that we have for continuous renal replacement therapy. We have a wonderful group of speakers, and with no further ado, I give the word to my co-chair to introduce the first speaker.
Thank you very much, Claudio. So the first speaker is Professor Vincenzo Cantalupi. He works in University of Piemonte Orientale at Novara in Italy. And Vincenzo, you are going to talk about the improvement of uremic complications. How can hemoadsorption help?
Thanks, Tom. Thanks, Claudio. So improving uremic complication, how can adsorption help? I start with what we have learned from Peter Stenwinkel at Karolinska. So CKD, chronic kidney disease, is a model of premature aging. This is the phenotype of our patients in chronic hemodialysis, characterized by cardiovascular hypertrophy, vascular calcification, osteoporosis, muscle wasting, and sarcopenia. And this low state of chronic inflammation is sustained by pro-aging factors such as hyperphosphatemia, angiotensin II activation, defective anti-aging mechanisms such as clot of vitamin D deficiency, and by the presence of a persistent inflammation and oxidative stress that trigger the aging processes. This inflammation is related to exogenous factors such as dialysis treatment itself, the microbiota in the gut, cellular factors such as cellular senescence, tissue factors such as hypoxia, sodium overload, and the presence of uremic toxins. And this is the classification of uremic toxins proposed by our chairman some years ago. And the most important thing, I think, that are these water-soluble large molecules, but in particular, what we cannot get rid of by standard dialysis is represented by protein-bound uremic toxins such as indoxyl sulfate and picoxyl sulfate. And we know that these protein-bound uremic toxins are able to non-covalently bind to albumin with about 90% of binding. So basically, these uremic toxins are produced by the gut, starting by tryptophan and L-tyrosine, indole and cresols. And you can see indoxyl sulfate, because this sulfate together with TMAO can reach, in condition of increase of the permeability of the gut, can reach the bloodstream, inducing different biological activity on different organs, including the cardiovascular and the kidney. And the P-boot levels are associated with chronic kidney disease. Basically, you can see higher is the stage of CKD, higher is the concentration in the blood of indoxyl sulfate and picoxyl sulfate. And if we compare the concentration of P-boots in CKD versus healthy individuals, you can see for indoxyl sulfate, we have about a 44 higher concentration in CKD than in healthy individuals. And the same in particular for the free and total part of picrazine sulfate are 22 and 11 higher respectively in CKD in respect to healthy individuals. So also in patients with acute kidney injury, we observed an increase in plasma of these protein-bound uremic toxins, not at the level reached in chronic kidney disease, but this is something also to take in consideration in the acute setting. And if you look at what happens after kidney transplantations to indoxyl sulfate, for example, you can see a significant decrease after kidney transplant. However, kidney transplanted patients with high level of indoxyl sulfate are more prone to develop cardiovascular event after the transplant. So the question is, protein-bound uremic toxins, why are so dangerous? There is an association with mortality, as detected many years ago in this paper on Kidney International. You can see a cutoff, for instance, for picrazole. High levels of picrazole are associated with mortality and with organ dysfunction. The lower kidney clearance of these secretory solutes are associated with CKD progression. These are the curve of secretory solute of the indoxyl sulfate clearance. So basically the reduction of this clearance is associated with the progression of chronic kidney disease, as demonstrated by the CRIC study. And basically these uremic toxins, such as indoxyl sulfate here, can reach through the organic anion transporter tubular epithelial cells, inducing damage. As we demonstrated with our chairman here some years ago, this is the effect on picrazole on renal tubular epithelial cells, the induction of apoptosis, and other biological alteration of tubular epithelial cells, such as epithelial to mesenchymal transition, senescence, in the release of reactive oxygen species, and so fibrosis, the histological finding of progression toward chronic kidney disease. But not only the kidney is the target of these toxins, also the cardiovascular system, as stated. And in particular, we have some studies indicating that serum indoxyl sulfate is associated with vascular disease and mortality in chronic kidney disease patients. A 5% increased risk of death for each 0.1 milligram milliliter increase in indoxyl sulfate serum level. And these experimental studies, the idea is that these uremic toxins can modulate the concentration and the biological activity of some molecules, such as clotho, within the vessels, and in particular within the heart. You can see here that indoxyl sulfate is able to methylate clotho expression. Clotho is an anti-aging factor, and as demonstrated here, the decrease of clotho level and the increase of indoxyl sulfate is associated with myocardial hypertrophy. So this is a possible pathway, not only in the heart, but also for the brain. In both the CKD and the AKI setting, we have different vascular and non-vascular factors that may lead to the disruption of the permeability of the blood-brain barrier, and also to the alteration of with the increased incidence of the so-called cognitive decline in patients with uremia. The idea is that these inflammatory mediators may alter the permeability of the blood-brain barrier, and some uremic toxins, in particular indoxyl sulfate, are able to reach neurons and glial, inducing neuroinflammation and neurodegeneration, also as detected for the heart, also in the brain, so basically accelerating what we can call brain aging. So I hope to have convinced you that protein-bound uremic toxins may have a role in cardiovascular and neurological alteration. And in the last part, I can see the therapeutic strategies to reduce PBUT. What we can do: reduce gut synthesis, gastrointestinal sequestration, reduce proximal tubular retention, but in particular, renal replacement therapy. We have some data on the removal of these protein-bound uremic toxins by standard hemodialysis with a reduction rate of about 30%, also using a diffusive strategy such as extended or nocturnal dialysis. You can see an increase of the reduction ratio, but this is mainly associated with a reduction of the free unbound percentage of this uremic toxin. The same field of this is observed for convective strategies. This is a study published on Journal of Nephrology by Vincenzo Panicchi, in which also HDF may be used to decrease the level of protein-bound uremic toxins. But once again, this is mainly related to the free part. As stated by our chairman, the use of hemoperfusion in end-stage kidney disease patients has been mostly overlooked due to inadequate sorbent materials and often neglected because of the side effects. But today, we have new biocompatible membrane sorbent. The idea is that hemoperfusion, this extracorporeal blood purification, can consist of the passage of anticoagulated blood through a device, and with different physicochemical properties going from van der Waals forces, ionic forces, hydrophobic interaction, can eliminate some of these uremic toxins. And today we will talk about HA130 hemoperfusion, this cartridge that is a neutral macroporous raising adsorbed beads. It's formed by these beads made of styrene divinyl benzene copolymer, indicator for this alteration of, we will see some slides in the next few minutes, for the removal of these uremic toxins, including protein-bound uremic toxins. So the idea is to add to the classical diffusion and conversion a third dimension that is represented by adsorption. And there is a consensus group on hemoperfusion, hemodialysis in Shanghai that suggests the use of these cartridges in patients. You can see for patients with severe pruritus, uremia-related sleep disorder, inflammatory state and protein energy wasting, or severe hyperparathyroidism of beta-2 microglobulin levels, restless leg syndrome, and neuropathy. The treatment frequency should be individualized for each hemoperfusion treatment. However, the idea is to perform hemoperfusion once a week or once every 2 weeks. The treatment methods, hemoperfusion is combined with every kind of diffusive or convective or mixed treatment, including HDF. The recommended treatment duration is 2.5 hours. And with this blood flow rate, obviously in cognation, the hemoperfuser should be connected to the dialyzer. And looking also for adverse reaction, that is recommended to see platelet count, white blood cells, so all the things related to the biocompatibility of the system. We have some clinical data, not only related to safety, but also to the efficacy of this combination of hemoperfusion and hemodialysis. In particular, I show you some studies. In this one, we can see the increased clearance of beta-2 microglobulin and parathormone with the combination of both HD or HDF with hemoperfusion. And this is related also to a reduction in pruritus, in itching of these patients. The same compounds, the decrease of parathormone and beta-2 microglobulin are also correlated in this pilot study in Vietnam with a reduction of mortality, in particular related to cardiovascular events. Other studies show the improvement of other parameters, in particular laboratory parameters, once again, such as hyperphosphatemia, the itching, and also some inflammatory mediators, such as C-reactive proteins. This is another important thing, because for other membrane, we observed also a decrease of the inflammatory state. You can see here the combination of HD and HP leads to a decrease of C-reactive protein, IL-6, and TNF-alpha, and very interesting also to a better reduction of hepcidin levels. Hepcidin is related to inflammatory-related anemia, and so that is responsible for EPO resistance, and so this is another important effect. To end my presentation, I only show some data from a pilot study from Italy made by Vincenzo Panicchi in the University of Pisa in 7 patients treated with combined hemoperfusion and hemodialysis, evaluating the VAS score for itching and some uremic toxins, obviously the protein-bound uremic toxins, picorazine sulfate and indoxyl sulfate. This is the system with the sorbent cartridge in series before the hemodialyzer. These are the characteristics. The hemoperfusion was performed twice a week during the first week and once a week in the following 7 weeks. These are the results on protein-bound uremic toxins with a significant decrease of indoxyl sulfate here on the left and picrosyl sulfate on the right when hemoperfusion was associated with hemodialysis in comparison to the group treated by hemodialysis alone. The itching score, the VAS score, was not statistically significantly reduced, probably also because we followed the patients only for 2 months. And so to conclude, this is a meta-analysis, once again proposed by our chairman, Claudio Ronco. We can say that putting together the studies, hemoperfusion, pure hemodialysis, can achieve the complementary elimination of a broad range of uremic toxins, effectively preventing and treating complications caused by long-term dialysis and possibly prolonging life expectancy. The take-home points, dialysis adequacy should not be based only on urea KT over V today, but we should consider the kinetics of other retention salts that are associated with adverse clinical outcomes. I show you the relevance of protein-bound uremic toxins, such as indoxyl sulfate, picrosyl sulfate in CKD progression, and end-stage renal disease-associated cardiovascular and neurological alteration. People are not removed if not the unbound free fraction by conventional diffuse and convective strategy, and so hemoperfusion, the use of adsorption plus hemodialysis, can be a good therapeutic option for end-stage renal disease, probably also for acute kidney injury, as we will see in the next minutes, and promising results from first clinical trials able to evaluate HE complications are still in the literature. Thanks for your attention.
Thank you very much, Vincenzo. We will do the discussion at the end. In the meantime, I ask my co-chair, Professor Rimelet from France, to present the application of adsorption in acute disease and critical illness. The paper presented by Vincenzo opens new hope and interesting options for the future. And I think that this is something we really need to further explore, creating some more evidence and more information. Now we will see about the acute patients.
Thank you very much, Claudio. So thank you very much to Jafron for organizing this symposium. Thank you very much for inviting me. So during the next 15 minutes, I'm going to talk about hemoadsorption in sepsis, in septic, critically ill patients. These are my conflicts of interest. I work with different companies in this field, including Jafron. This is the outline I'm going to follow in the next few minutes. I'm going to come back on general considerations about the host inflammatory response in sepsis. Then I'm going to review with you the literature on what's available in sepsis with the Jafron technology. And then I'm going to finish with a few questions that I think we should be focusing on during the next years. So what is this host inflammatory response in sepsis? First, 2 slides on epidemiology, because I think they are very important. I've been working in the ICU for 20 years, and I always heard that sepsis is the primary cause of deaths in the ICU. No debate about this. But recently, like from data released 2 years ago, we know now that sepsis is not only the primary cause of death in the ICU, but it's also the primary cause of death in the hospital. In all hospitals, outside the ICU, sepsis is the primary cause of death. This is data from the US, from 5 large academic centers, and they looked at all the causes of death in all the patients who died at this time, during this period. And sepsis, as you can see here, was by far the primary cause of death in the hospital. Another study that I really enjoyed to read, it's this one, published in The Lancet 2 years ago. It's global mortality about sepsis. And if you look here, we learn that if you look at all the causes of death on the planet every year, we learned that 50 million people die every year on the planet from all causes. 50 million, it's also the number of sepsis, cases of sepsis worldwide every year. And we know that 11 million people died of this condition every year. So sepsis represents 1 in 5 deaths worldwide. And in the past, we thought it was by far less. So this is twice as many as previously estimated. I think this is very important to acknowledge this new epidemiologic data. Another important thing about this host inflammatory response is what was said by Sir William Osler already 100 years ago. He said that except on few occasions, the patient appears to die from the body's response of sepsis rather than from the infection itself. 14 years ago, the pathophysiology of this inflammatory response was well described by Richard Hotchkiss. And what did he say? He said that this inflammatory response, you have 2 inflammatory components, the pro-inflammatory components and the anti-inflammatory components. Both components occur at the same time, but the net balance is more on the pro-inflammatory side during the first hours of the sepsis time course. And then after a few hours, the net balance is on the anti-inflammatory side. All of this is due to the release of all these inflammatory mediators, these cytokines. And this is very important to remember that now we know that this immunosuppression state is extremely deleterious for the patient because at that moment in the ICU, the patient cannot fight against nosocomial infections, cannot fight against viral reactivations, and that's why 80% of the people who die from septic shock, they die because of this immunosuppression. Okay? This is very important to now understand this. Immunology is now part of our daily life in the ICU. Every day we now are going to get results from the immunology department to better understand how these septic patients deal with these organ dysfunctions. And you know, it is even in the definition of the sepsis. Like 7 years ago now, published in JAMA, the new definition of sepsis, sepsis should be defined as a life-threatening organ dysfunction caused by a dysregulated host response to the infection. So the host response is now part of the sepsis definition. That's very important. When we manage sepsis patients in the ICU, we pay attention to 3 very important things. Of course, the antibiotherapy, as early as possible and as well adapted as possible. The source control is, of course, very important. If the patient needs to go back to the operating room to get operated, for a peritonitis, for example, he has to go to the operating room as quick as possible. And of course, this is our daily job in the ICU. We deal with organ support, right? If the patient has hemodynamic impairment, we deal with fluids and with norepinephrine. If the patient has respiratory failure, we need to intubate the patient. If the patient has kidney dysfunction, of course, we need to provide renal replacement therapy. But still, if we do this very correctly, the 3 things very correctly, the mortality rate is still more than 40%. So that's why we need to find, in the upcoming years, some adjuvant therapies if we want to decrease this mortality rate. And at this time, immunostimulation, like in the cancer field, immunostimulation is under evaluation with IL-7, with GM-CSF, interferon gamma. But also, what I'm going to talk now is all this field of extracorporeal blood purification techniques that you can see here with one of the Jafron cartridge. These extracorporeal blood purification therapies are under evaluation in sepsis. This is also something I'm reporting here. You know, this is sepsis-induced acute kidney injury. The pathophysiology is very complex. We don't really know how these circuits, You know, this is like a CVVH circuit or a CVVH, this is a CVVHD circuit. And if you place here a membrane with, of course, some specific properties able to provide some blood purification properties, but also these hemoadsorption cartridges, we don't really know how they are going to interact with this pathophysiology of sepsis-induced acute kidney injury. There are some possible mechanisms that we need to better understand, and we need to understand if this is good to remove endotoxins, because you know, the endotoxins are the trigger of the inflammatory response. Claudio, 20 years ago, this is kind of an anniversary, right, Claudio? 20 years ago, you published this peak concentration hypothesis that with these techniques, we can decrease the peaks of these cytokines. The peaks of cytokines can be decreased by these therapies. With Professor Kellum in the US, we developed the chemokine concentration gradient hypothesis, which is that, you know, between the tissue, like let's say this is an infected lung here, a pneumonia, and you have here the blood circulation, then there is a gradient of cytokines, a gradient of chemokines, and we know for sure that this gradient is extremely important to drive, for the leukocyte trafficking, to drive the white blood cells to the site of the infection. And by applying a blood purification device here, you can modulate this gradient, and maybe this is why you can drive the PMNs to the site of the infection and improve outcome. That's also a hypothesis. Another hypothesis which needs to be validated is the adsorption of not cytokines, not endotoxins, but the cells by themselves. The white blood cells can be adsorbed on the divinyl benzene beads. Okay, so maybe there is an interaction between the sorbent and the leukocytes, leading to the modification of the expression of some leukocyte surface markers, like HLA-DR. And I think this is very important because HLA-DR, as you may know, is a great marker of this immunosuppression state. Now here, we are not immunosuppressed, I hope, and we have an expression of monocyte HLA-DR of 15,000, of 20,000 antibodies per cells. But in the ICU, when the patient is with sepsis-induced immunosuppression, the level is very low, it's 5,000 antibodies per cell, showing that there is this immunosuppression state. So we need to work on all these hypotheses. In 2023, we have all these techniques available. We have the sorbents, so you run the blood through the sorbent, so the cartridge. You have polymyxin B hemoperfusion. You have other companies providing some devices, and we have the cartridges from the Jafron, HA330, and now for sepsis, we have this HA380, which has been released recently. The CRT filters, the random CRT filters, they also can provide some specific properties, providing an addition blood purification property. Auxiliaries filter that you may know, the high cutoff membranes, they not only provide kidney support, but they also provide blood purification by the removal of inflammatory mediators. We have new blood purification techniques from the last 5 years. The Seraph, for example, from the Xterra company, the Seraph, this technique is able to remove from the blood bacterial components. And then we have also circuits from the US that are also very interesting. In the past, we used high-volume hemofiltration, cascade hemofiltration, pulse high-volume hemofiltration to remove these cytokines. Plasma exchanges also can be proposed for blood purification, and CPFA. So now, what's the literature about hemoadsorption with the Jafron cartridges? Well, I think the most important publications are the ones I'm going to show now. This is a Chinese study comparing two groups of 15 patients. One group received CVH in the renal dose, 35 ml per kilo per hour of CVVH, and then the patients were compared to pulse high volume hemofiltration. So they received 6 hours of 85 ml per kilo per hour, in addition to, during the rest of the day, it was normal CVVH, plus hemoadsorption with the Jafron technology. And if you look at the cytokine levels after 24 hours, but even after 2 hours, IL-6, IL-10, and TNF-alpha, the concentration was decreased in the group of patients who received the combination of pulse high volume hemofiltration and hemoadsorption. This is a study from our friend from Bangkok, from Professor Skizawat. He took COVID patients, and he took the most severe COVID patients. He did not take the non-severe patients, like they have been excluded from the study. And then he ran hemoadsorption with the Jafron technology in these patients. In 15 patients, they received just 1 or 2 sessions, and in 15 other patients, they received more than 3 sessions. Look at the mortality rate in these patients. The ones who received more than 3 sessions of hemoadsorption all of them almost survived. And the ones who did not, unfortunately, died. I don't like to show in meetings case reports, but this one, I couldn't help myself. I wanted to show you this case report from Turkey. This is a 42-year-old patient. This patient got a symmetrical peripheral gangrene in the feet and the hands after hematopoietic stem cell transplantation. Look at the feet and the hands of this patient. Sometimes we get these patients in the ICU, and when we see these feet and the hands, usually, almost all of the cases, I've never seen that there is no amputation of the fingers. This patient received 3 sessions during 3 days of hemoadsorption with the cartridge HA330. The blood flow was 200 ml per minute, and 1 session lasted 150 minutes. No amputation was performed. All of them, I mean, the feet and the hands got much better after the sessions. This is another study from, it's an observational study from Turkey, and the table here comparing the survivors and the non-survivors. It's 11 patients who received also hemoperfusion with the cartridge from Jafron. Actually, it's not so important to compare survivors versus non-survivors because they're not so different. The patients were very severe. The mortality rate was 60%. What was interesting in this study is that they selected among all their patients the ones who could benefit from hemoadsorption. And they took the ones who were the sickest, right? Use of high-dose vasopressors in the ICU, dysfunctions of more than 2 organs. So I think it's very important to this technology is probably not for all septic patients, of course. We have to select the sickest one. I think the selection of these patients is key. For the next few years, this is what I think we should focus for the research. Sometimes in congresses like this one, especially in the intensive care field, we hear that, blood purification doesn't work. We have large randomized controlled trials that are negative, so blood purification just does not work. We hear this, and I'm sorry, but I strongly disagree when I hear this for several reasons. First, because they are telling you that all studies are negative. This is totally untrue. This is a randomized controlled trial. This is a meta-analysis from Professor Kellum in the US. He took all the hemoadsorption studies and reported a signal in favor of hemoadsorption. Claudio, you know this study, right? It published in JAMA, 2009. Positive trial. Okay, this is a positive trial with polymyxin B hemoperfusion. So it's untrue to say that all data is negative. This is another one. It's very interesting because this is a Euphrates trial, polymyxin B hemoperfusion in septic patients. the whole study is negative. But when you look again at a specific subpopulation of patients, then the signal becomes positive. So that's interesting also. And then all these studies negative, they are here. The Ivoire study with high volume hemofiltration, Abdomic study with polymyxin B hemoperfusion, Compact one with CPFA, they are negative, true. But they are full of limits. And when a study is negative, it's interesting to see that people, they don't talk about the limits. When a study is positive, yes, let's look at the limits. But when a study is negative, nobody is talking about the negative. Nobody is talking about the limits of the study. Then if you don't believe this data, if you don't believe if blood purification is good or not, if you don't believe Claudio, if you don't believe me, then just ask the sepsis experts, which we are not, right? Let's ask these guys, what do they think about blood purification? They are telling us that the evidence is too low in favor or against the blood purification techniques. So additional research should be done. And this is what we keep saying with Claudio and many other people, the Acute group, more research is needed in this field. Why these studies are negative? For sure, because of this reason. In these sepsis trials, they took all the patients in the ICU who were septic. The gram-negative sepsis, the coccigram-positive sepsis, the sepsis from the urinary tract, the pneumonia, everything together. When you do this, you can do everything, but you know it's going to be negative because you are not going to see the positive effect on the subpopulation of patients. This is very important to understand. And be careful also because all these companies, they provide new devices years after years. And the gap between the technological progress and the medical knowledge of the pathophysiology is increasing, I think. So basically, we don't know how to use these therapies. We don't know which patients exactly, how to select the right population. When do we need to implement these techniques? Which timing? We don't really know. And what to remove? I told you at the beginning that there are many things we can remove. Now we can even remove the bacteria, the viruses. Everything can be removed with all these technologies. But we don't know which one is best to remove. So in conclusion, my take-home message is, first, 2023, immunology is part of the sepsis definition. It's part of our daily clinical practice in the ICU. The patients that die of septic shock because of sepsis-induced immunosuppression, will these techniques, blood purification techniques, be one day part of the sepsis management? I don't know, but blood purification techniques, such as hemoadsorption, are currently under investigation, and we need to do this seriously. These multi-center trials were negative. Were they well designed? That's the question. We have many unanswered questions that needs to be answered. How do they work? Which patients exactly? When exactly? Which timing? What to remove? Cytokines, endotoxins, leukocytes, bacteria, viruses. So I hope I was able to convince you that research in this field should definitely continue. Thank you very much.
Thank you very much, Thomas. I have one question for the audience. How many of you use continuous renal replacement therapy in intensive care when they have a critically ill patient with AKI? Okay. How many of you use intermittent therapies? So you all use renal replacement therapies. 30 years ago, there was a debate whether renal replacement therapy in ICU in critically ill patients should be provided to patients or not. And today, everybody is using this. I think we are exactly at the same point where we were 30 years ago. Now, we have, I think, a video because Professor Chen could not join us. And here is the video.
Dear Chairman, dear colleagues, my name is Jinjun Chen from Hepatology Unit, Nanfang Hospital, Southern Medical University, China. I am very pleased to be here to share the preliminary data of PASTON study. The PASTON study is the first one trying to investigate TB therapy in critical liver disease. This time, I will share the study design and the safety data of TB therapy in this ongoing study. As we all know, acute and chronic liver failure patients generally will suffer multiple organ injuries or organ failures. However, for lung failure or kidney failure, we have therapeutic options for all patients. And for liver failure, therapeutic plasma exchange and DPMAS are having more and more positive data. As we all know, the DPMAS working mode is including two categories. One is the BS330, which is for adsorption of total bilirubin bile acid. And the second one is the HA330-2, which is designed for adsorption of inflammatory mediators like middle molecular toxins. And in China, the popular modality of artificial liver support is, the first one is the therapeutic plasma exchange alone, and the second one is the DPMAS alone. Recently, DPMAS combined with therapeutic plasma exchange are much more preferred by clinical doctors. However, so far, there is no prospective and large-scale study on DPMAS in liver failure patients, and there is no prospective safety data on DPMAS combining with therapeutic plasma exchange in our patients. Therefore, we start a PISTON study at 2021. The PISTON study is a prospective, multi-center, and cluster-controlled study, which is focusing on to precise profiling of ACL patients and DPMAS therapy, try to find out who will be responsible for DPMAS therapy, and finally achieving a good endpoint. I am the leading investigator from Nanfang Hospital, Southern Medical University. At the beginning, we screened 57 teaching hospitals in the field of liver disease, infectious disease, and digestive disease across all China. We divide the scientists into DPMAS group, which has much more experience on the DPMAS therapy and plasma exchange therapy. And the other centers are divided into standard of care group, which is not very familiar with DPMAS or plasma exchange, or they do not have the devices. The sample size of the PISTON study will be 1,300 patients, and 650 patients will be included into each group. This is the distribution of our research centers. We can see that all centers are across all China. The flowchart of PISTON study, the first thing is that we will screen adult patients with chronic liver disease regardless of the etiology. The total bilirubin will greater than or equal to 12 milligrams per deciliter, and the international normalized ratio will be greater or equal to 1.5. For the exclusion criteria, the first is the patients with 3 or more organ failures. We consider patients with 3 or more organ failures will be much more suitable for liver transplantation rather than DPMAS or plasma exchange alone. The eligible patients will be divided into DPMAS group of standard of care group according to the centers they are treated in. And the primary outcomes of PASTON study include the 4-week mortality and or 4-week disease progression. The disease progression is defined as for the patients cannot be diagnosed as ACLF according to the ESO criteria, and the disease developed within 4 weeks or 3 months developed into ACLF, that will be defined as disease progression. The secondary outcomes of PASTON study includes 3 months mortality or disease progression. And we will follow up patients 2 to 48 weeks to look at the outcomes, the survival status, or liver transplantation status. The case schedule of our PASTON study includes, at the beginning, we will screen and include 1,300 patients. We will divide the patients into DPMAS group or standard of care group according to the centers they are stayed. At the baseline, we will collect samples including plasma, urine, and stool samples from interested centers for both DPMAS group and standard of care group. And for DPMAS group, we will also collect plasma samples just before and after the first DPMAS therapy. These samples will be centralized to our biobanks. We will follow our patients at 4 weeks and at 12 weeks closely to look at the survival status, liver transplantations, or disease progression. Due to January 5th, we have 24 active centers for DPMAS group and 25 active centers for standard of care group. Finally, we screen and include 641 cases into the DPMAS group and 475 patients into the standard of care group. And the following slides will show the centers, active centers' contribution to the DPMAS and standard of care group. I will show the very preliminary data of our patients in the DPMAS group, and we are working hard to clean and log the data, so this data will be changed sometimes. And for the baseline of 641 patients in the DPMAS group, the etiology is much more different from European patients, as hepatitis B infection is the majority cause of our chronic liver disease in our patients. And 25.3% of our patients can be diagnosed as ESO-ACLF. We then look at the DPMAS treatment mode. We see that only 22.1% of our patients are treated with DPMAS alone for the first DPMAS therapy. And the remaining 77.9% of patients are treated with DPMAS combining with therapeutic plasma exchange. That shows that the combination therapy mode are most accepted by our doctors. If we look at the number of DPMAS therapies, we found that around 1/3 of patients are treated with a single DPMAS therapy, and the other 1/3 of patients are treated with double DPMAS therapies. And 20% of our patients are treated with 3 DPMAS therapies in the study. The remaining 20% of our patients are treated with 4 or more deep mass procedures. That means that we do not have the consensus recommendations for the number of deep mass therapies in our liver failure patients. And if we look at the technical details for the first deep mass therapy in our patients, we found that the plasma treatment volume of the first deep mass treatment mostly is greater than 5,000 milliliters, and only 25% of patients with plasma treatment volume less than 4,000 milliliters. As we all know, liver failure patients always has coagulation injury or failure. However, we can see that only 4.7 patients, they do not have any anticoagulants in the first deep mass therapy. If we look at the blood cells counts before and after the first deep mass therapy, we found that the wild blood cells counts increased after the first deep mass therapy. And contrary, the platelet counts and hemoglobin levels significantly decreased with the first deep mass treatment. If we look at the treatment-related complications, we found that only 12.4% of our patients with significant adverse events, which includes consumable-related, like membrane rupture, coagulation in the cartridge, or in the dialyzer. Also includes the patient-reported adverse events like bleeding, lip pneumonias, allergy, and hypertension, and others. However, we can see that 87.6% of our patients, they do not report the adverse events related to the deep mass therapy. So this is by far the biggest prospective data of deep mass in liver failure patients. The deep mass therapy shows a very good safety profile. And for the anti-clot strategy in the first deep mass therapy, we found that the heparin is the most commonly used, and the second one is a low molecular weight heparin or citrate. The in vitro clot found only 1.7 in patients treated with a low molecular weight heparin, and 0 in the 58 patients treated with citrate as the anti-clot strategy. That will open the question that which anti-clot drugs is most suitable for liver failure patients. If we look at the immediate responses of first deep mass therapy, we found that the total bilirubin levels significantly decreased after the first deep mass therapy, which is around 100 micromole per liter. And if we look at the C-reactive protein levels or pro-CT levels, which both reflect the inflammatory conditions of liver failure patients, we found that both biomarkers decreased significantly after the first deep mass therapy, which shows that the deep mass therapy will ameliorate the inflammatory condition of our patients and balance their responses. We are closely monitor and follow up our patients. Hopefully, we will clean and log the primary and the secondary outcomes data at November this year. hopefully, I will have opportunity to share the outcome data in the future. We have the final case enrolled on April 15, 2023. Hopefully, we will finish all endpoints follow-up July this year, and if everything is okay, we will have the clean and locked data for the outcomes and other details. So next April, I will have opportunity share the data analysis. Finally, I will thank all my collaborators from the 47 centers and the Chinese Foundation for Hepatitis B as the sponsors, and the Jafron Limited, and the CRO company, and the CSC colleagues, and all my patients. Thank you very much.
So very good. In spite of the embargo on the information of the clinical results, you have realized that this is one of the largest studies ever done in liver failure and probably in blood purification in critically ill patients. 1,300 patients is a huge number of patients, and we're really looking forward to see. The other important information is that you have seen that the large amount of patients received more than 5,000 liters of processed plasma. So this is definitely much higher dose compared to what we normally see in these patients. I'm really looking forward to see the results. Do we have quick questions for Professor Cantalupi, Professor Rimelet? Please.
Thank you very much for the comprehensive summary. My question is for Professor Rimelet. I know that this doesn't have a yes/no answer, but I really wonder in which patients shouldn't we insist on continuing the hemoadsorption therapy? I'm not talking about the very terminal patients. Like, of course, for the very terminal patients, we may decide to stop. But for the others, not the very ill, very terminals, but for the others, what should avoid us from insisting on the therapy? Yeah, I know we should start as early as possible, and I myself believe in the power of this therapies, and the evidence is clear. But I hope you got my question. Thank you.
So, Thomas, when do you stop and when do you continue?
So, of course, this is a very difficult question, and we don't have the right answer, but I can say a few things. First, there are different techniques. There are different cartridges and different sorbents, and you need to know the one you have in your unit, which is the target. Because, of course, if you have a cartridge, a sorbent that targets the endotoxins, it's not the same as if you have a sorbent that targets the cytokines, right? Then, when to stop? Yes, we need to stop as early as possible. And as you said, we are not going to start in all septic patients, right? You need to start, as you said, I think, in severe patients. You select correctly a population, and the ones they did, the strategy they used in Turkey, I think was good. They took patients with different organ dysfunctions, and then they see. To stop, Claudio, I think we need to see the answer, the feedback of the patient. How does the patient reply to this initiation of therapy? If you have an improvement, and usually what you look at, it's the vasopressor requirements, right? We look if the vasopressor requirements is decreasing. And if yes, I think we should go for another session. If there is no improvement after one session, I don't think, then in this situation, we don't apply another one, okay?
For the general experience we mature on the field, we normally prescribe in the people with impending cytokine storm and cytokine release syndrome approximately 1 or 2 sessions in the same 24 hours at the beginning in order to really prevent organ damage, etc. And then we follow up in the next day and the other day with another session every 24 hours in case there is a response. But according to our experience, after 2 sessions or 3 sessions, you see immediately a reduction in the amount of noradrenaline that you require to maintain hemodynamic stability. So again, you cannot expect then hemoadsorption to cure the patient or every patient forever and for every cause. If a patient has peritonitis, you need to send to the surgeon to re-laparotomy and so on. But the important aspect, in my view, is the early application, try to identify the early responders, insist in case you have a blunted response, or you may stop in case you have a very excellent and good response. We have time for one more question, which I have for Professor Cantalupi. Vincenzo, you mentioned that protein-bound toxin can be dangerous, and I think that offering this type of therapy, we are offering something that so far we never explored, right? So can we expect maybe the use not only in patients for rescue therapy of symptoms, but in the future to prevent those symptoms?
Yeah, I mean, it's probably, this is the case. This is something that we have to explore because we don't have results. The results on classical diffusion and convection and the limitation to diffusion and convection are always more related to the unbound free fraction of protein by uremic toxin. So I think, yes, we are running together a kinetic studies, and this is also in my way the first thing to do to understand the removal of these harmful mediators. And then I suggested two potential applications that are obviously the most important alteration in our patient, in chronic dialysis patients, such as cardiovascular and neurological alteration that is highly underestimated. We have different sessions in this Congress about cognitive decline and neurological alteration, not only related to the vascular compartment. And so I think that after the kinetic, we should plan some more studies focused on clinical efficacy and long-term evaluation.
Yeah. So in the consensus conference of ADCI, we will come up with a manuscript where we stated that because it is going to be difficult to do prospective randomized trials, probably data collection and registries will be very useful. And we will provide a suggestion on a minimum set of data to record and collect when you do treatments for hemoadsorption. In this case, I want to stress the point that everybody of you can contribute to this information. So in the future, we will collect data, but possibly we need the same set of data in order to be able to establish some time of rules, indications, and characterization of patients. Everybody of you can really contribute to a small piece of information that we may need to expand our knowledge in this field. With this, I thank the speaker, my co-chair. I thank Jafron for organizing this thing and to provide the substrate for so much research. Thank you very much.